Welcome everybody to July's Wellbeing, Health and Youth NHMRC Centre of Research Excellence in Adolescent Health seminar series. And so first off, I just want to acknowledge the funding support that we have from the NHMRC and the contributions of our research partners in universities across Australia that are here. And for those of you who don't know me, I'm Professor Rachel Skinner, and I am Deputy Director of Wellbeing, Health and Youth Centre of Research Excellence. So I'd like to acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. And we pay our respects to their elders past, present and emerging. And I'd just like to say that I'm joining you from Gadigal country today. So you might like to share the countries that you're joining in the chat from. And to remind you that we have a website which has lots and lots of really great resources, and it's our community of practice. It's a place where researchers, clinicians and policymakers and young people come together to share ideas and exchange information. So please check it out if you haven't, or take another look to see what else is new there. So just to orient you, we have a chat function. So your microphone will be muted. You can't actually ask questions verbally, but you can post them in the chat function. So down the bottom right hand, you can pop them in, and at the end, we will highlight the questions and we'll go through the questions. So please do that as you go. As you think of a question, please pop it in the chat. Great. So today we are really lucky to have Dr. Hiba Jebel. I hope I've got that right. Jebeli, is that right? Anyway, you can correct me. An early career researcher and dietitian at the University of Sydney. Her research examines the effect of obesity interventions on eating behaviours and mental health. And Hiba is a co-lead and program manager of the Eating Disorders in Weight-Related Therapy Eat It collaboration, assessing individual eating disorder risk during obesity treatment in adolescents and adults. So thank you very much. Hiba, I'm going to hand it over to you now.
Thanks, Rachel. And thanks for having us today to present on our collaboration and on the work that we've done so far. So first, I'd just like to acknowledge the Darug people as the traditional custodians of the land that I'm presenting from today here in Western Sydney, and pay my respects to elders past, present and emerging. So today I'm going to be talking about one of the first the consultation process that we've done as part of the work of the Eating Disorders in Weight-Related Therapy collaboration, or the EDIT collaboration. So I'll start with a bit of background as to how the collaboration was formed, what our overarching aims are, and then talk a bit about our consultation process so far.
I think that we've got a bit of an issue. A couple of people have said that they're not getting sound through. So I'm not sure, Sharon, if you can give us a hand, or somebody could give us a hand to make sure that that's whether or not that's happening, if I've done the right thing, or some other people
okay,
are hearing.
some people
okay. Okay, so no, it's okay. Sorry, keep going.
Okay, but that's
maybe
okay.
Just specific to those people. I might have to, log out and log back in again or something.
Okay.
Great, thank you.
I'll keep going. Okay, so eating disorders are really a complex group of psychiatric illnesses which often present as disordered eating behaviours, and they can have significant comorbidity and mortality as well. So eating disorders generally can take several years to develop, or can develop over time, and they may begin here with some, a broad number of people may have eating disorder risk factors, such as disordered eating attitudes and behaviours, have some body dissatisfaction, overvaluation of weight and shape, or be engaging in dieting behaviours. Things like depression, anxiety and having low self-esteem are also risk factors for eating disorders. For a group of people, that may progress to having more subclinical eating disorder symptoms, so where they may engage in more extreme disordered eating behaviours, but not quite reach the frequency or threshold for a clinical diagnosis. So, for example, they may have more infrequent binge eating episodes or engage in some irregular compensatory behaviours. And then for a smaller number of people, again, they may progress to a clinical eating disorder. So on the other hand, obesity, really the prevalence of which has been increasing over the last few decades, and pre-COVID in developed countries that was starting to plateau, but was continuing to increase in low and middle income countries. And now during COVID, particularly in younger children, we are seeing an increase again. And I know this slide may be a bit small for you, sorry, on this screen, but obesity is associated with really a range of comorbidities and complications which can progress into young adulthood, affecting virtually every body system. So we do need both effective and safe treatments for obesity in young people. So while eating disorders and obesity were historically considered to be on opposing ends of a weight spectrum, there is actually quite some overlap between the two conditions. So for example, there are several areas where they have shared risk factors. So if we consider the environment or environmental risk factors, things like weight teasing, internalized thin ideals or beauty ideals, and media exposure, particularly social media, are risk factors for both weight gain and disordered eating. They also share cognitive risk factors such as weight concern and body dissatisfaction, and behavioural risk factors. So engaging in unhealthy weight control behaviours, such as binge eating or loss of control eating, contribute to both disordered eating and the risk of developing an eating disorder, but also to further weight gain. There are also components that are commonly part of weight management interventions, which are eating disorder risk factors. So for example, weight loss or aiming to attempt weight loss, having more extended or larger amounts of weight loss is a risk factor for eating disorders, and is one of the diagnostic criteria, for example, for anorexia nervosa. Dietary restraint or dietary restriction or dieting is a risk factor across the eating disorders, as well as weighing and monitoring type behaviours. So monitoring weight, calorie counting, and particularly when they become a bit more obsessive and more frequent, are also sort of red flags and risk factors for eating disorders. So really, over the last sort of decade or two, this has raised some concerns about what the role of weight management interventions and treatments for obesity are in terms of eating disorder risk. So a few years ago now, our team wanted to really look into this issue and have a look at what the impact was of weight management interventions on eating disorder risk, but also on psychosocial health more broadly. So we conducted a series of systematic reviews, which had the overarching aim to assess the impact of weight management interventions. We focus on interventions with a dietary component because we were really interested in that dieting aspect of interventions conducted in children and adolescents with overweight or obesity. So we have three main reviews which we've published looking at eating disorder risk, depression and anxiety, and body image and self-esteem. And across the series of reviews, we reviewed about 110 unique studies. So I'm going to just briefly present the results of each of these reviews. So the first of the reviews looked at eating disorder risk, and we looked at several different outcomes. So we looked at global eating disorder risk, binge eating, bulimic symptoms, so using compensatory behaviours such as self-induced vomiting, emotional eating, drive for thinness, and eating concern. And really across studies, when we looked at the mean change over time, we found that there was either no change or a small reduction in risk at both post-intervention and at follow-up time points in the follow-up. There were some studies with follow-up of sort of 12, 24, and 36 months. There were some studies that had a look at whether people moved to above or below predefined cut points, so as being sort of high risk if you're above a particular cut point. And there were some studies that reported a reduction in the number of participants who were above the cut point, sort of where people were moving to being below the cut point, particularly for binge eating and bulimic symptoms. There were 3 studies, though, that did report on individual participants. And in those studies, they reported very small numbers of people who had a worsening in their eating disorder risk. So, for example, there was a study that reported 3 people had developed binge eating disorder at a 6-year follow-up time point. In another study, there were 7 people who moved to being from below the risk cut point to above the risk cut point. And then another study which reported the onset of binge eating behaviours in 4 people. Now, it's important to note that in this review and across our reviews, there were very few studies that were RCTs, which included a no treatment control. So we weren't able to really have a look at change in risk compared to a group that didn't receive a weight management intervention or to not receiving treatment. So when we looked at some of these other psychosocial health outcomes, which are also risk factors for eating disorders, we saw a similar pattern across the board where symptoms of depression, anxiety tended to reduce. So there were improvements in those symptoms. And we saw that body image and self-esteem tended to improve as well at both post-intervention and follow-up. So in another follow-up to these reviews, we wanted to really explore the role of dieting a little bit more. So what we did in studies that had reported a subscale of dieting or dietary restraint, we really had a look at how this, what this change was compared to changes in the other markers of eating disorder risk. So I know this table is a little bit busy, but what I've listed here are the studies that had an increase in dietary restraint or dieting behaviours in at least one of their intervention arms. So they're listed just here on the left. Then in the yellow, you can see their dieting or dietary restraint scores as having increased in at least one arm. There were some arms that had no change. And then across the table, you can see the change in other eating disorder outcomes. So in green, there's body image and self-esteem, and they tended to improve or remain unchanged. And then in between, there are some of the other disordered eating outcomes, so binge eating, emotional eating, and global eating disorder risk. And really, again, they tended to either not change or have a small reduction. So really, in this context of weight management, we saw that even if the dietary restraint or the dieting score increases, some of the other eating disorder markers either didn't change or reduced. So it showed that perhaps in this context, markers of dieting or dietary restraint are not necessarily good indicators of eating disorder risk. So from these systematic reviews, we really saw that structured weight management interventions on the whole was not associated with an increase in eating disorder risk for most children and adolescents, but that there may be a small subset that do have a worsening of symptoms. But we do need further long-term data. At the same time, there is quite a strong lived experience voice within the eating disorder community who attribute the development of their eating disorder to weight management and their experiences of weight management, particularly as children. There have also been case reports of adolescents who've developed an atypical anorexia nervosa following recommendations to lose weight by a health professional, often in unsupervised weight, but the recommendations were made. And there's also been a couple of other studies that have had a look at adolescents who are presenting to eating disorder services with a restrictive eating disorders, and they've found that about 40% of those adolescents report having a history of overweight or obesity. So there is some link there, and we're hoping to be able to understand what that link is. So really, this research to date had identified 2 gaps and research questions that we were hoping to address. So the first is whether there is a subgroup of individuals who are at risk of developing eating disorders during weight management, and whether there is a way that we may be able to identify them early, and then whether there are intervention components that may contribute to eating disorder risk. So we looked at dieting in a bit more detail, but interventions are complex and they contain a large number of different moving parts. So we wanted to know, or we hope to understand, if there are particular components that may influence eating disorder risk more than others. So we were fortunate to be successful with an NH and MRC Ideas grant last year to answer these research questions. So from that, we formed the EDIT collaboration, And so the collaboration really has four main aims. So the first is to understand which participants are at risk of developing an eating disorder during weight management. We hope to understand which components of weight management interventions may contribute to eating disorder risk, and then hopefully identify predictive pathways for either an increase or decrease in eating disorder risk during weight management, and then develop some resources and recommendations for clinical care. So this just provides an overview of the collaboration. And so you can see it's a very large collaboration. So we have our study team, which is conducting all of the project management and research. Our work is overseen by both a scientific and stakeholder advisory panel. And these panels include people with clinical, research and lived experience, expertise across both eating disorders or obesity or both conditions. And so far, we've had 46 trialists who have agreed to join the collaboration and share their trial data with us so that we can, our aim is to pull that data together to be able to answer those research questions. So this just provides really a broad overview of the work of the collaboration. So what we did is we started by conducting a systematic search to identify trials that have looked at eating disorder risk during weight management interventions. And we have asked all of those trials if they will share their individual participant data to be pulled into a larger data set to answer these research questions. So first up, we conducted a consultation survey, and that's what I'll talk through in a moment. And then with the data that we've collated and the trials, we will be conducting two studies, which is study 2 and 3 here on the figure, which are individual participant data meta-analyses. And these are really hoping to identify individual predictors or individual risk factors that may predict a worsening of eating disorder risk during weight management interventions. Study 4 will be deconstructing those interventions into the individual strategies that may be used and having a look at whether there are particular strategies that are more likely to increase or decrease eating disorder risk. Then we hope to bring the results of studies 2, 3 and 4 together to conduct some predictive modelling and to really have a look at the interaction between individual characteristics and intervention strategies and whether there are different pathways that may be appropriate for different people. And then hopefully all of that will lead to some recommendations for translation. So what I'll be talking about for the rest of this presentation is the consultation survey that we conducted earlier this year. So really the aims of our consultation survey were to assess opinions on individual characteristics of a person which may contribute to their risk of developing an eating disorder in the context of weight management, and strategies used within weight management interventions which may increase or decrease eating disorder risk. So we started by developing an initial list of individual characteristics and intervention strategies that may be relevant to eating disorder risk from the literature. Then with our scientific and stakeholder advisory panels, we conducted 3 workshops really to go through those lists and refine them, and then to add anything that may be missing from the literature but may be relevant based on their clinical experience or expertise. We then clustered those items into smaller groups and put that together as a cross-sectional survey. The survey was circulated internationally through professional organisations and on Twitter. So the survey had 3 parts. First was to look at the individual participant characteristics. And so there were 6 categories that we used, or 6 clusters that we included in that section. So looking at demographics, weight status of the person, their medical and family history, their mental and psychosocial health, eating behaviours at baseline prior to coming into an intervention, and their history of dieting. And we asked participants to rate the relevance of each of these characteristics to eating disorder risk in the context of weight management. The second part had a look in more detail at intervention strategies. And there were 5 different clusters of intervention strategies. So the overall intervention framing and outcomes and how they were measured, their dietary strategies, how they may address eating behaviours and disordered eating, movement and sleep-related strategies, and psychosocial health-related strategies. And for each of those strategies, we asked people to rate if they were more likely to increase or decrease eating disorder risk, or if they had no impact on risk. And then the final part of the survey looked at different delivery features. So who delivered the intervention, the setting, the mode of delivery, the target population, and the support provided, and how important that was to consider in eating disorder risk. So just to give you an idea of the number of different items that we had identified and were included in this survey. So just looking at the individual characteristics, we had 50 different characteristics that we asked people to examine and rate across those different clusters that I previously mentioned. So similarly with intervention strategies, so across the 5 different categories, there are over 100 different strategies that we had identified which may be relevant to eating disorder risk. And so here this has the overarching categories, and then within each category, there are again individual clusters of different strategies. And just to give you an idea, within each cluster, there are then several strategies, individual strategies that are listed. So here I've included the dietary category as just an example. So within that overarching dietary category, there are 5 different clusters, and within each cluster, there are between 3 and 7 individual strategies. So really taking it down to a very detailed level. So for example, not just asking if they asked people to monitor their diet, but did they ask them to monitor it using a food-based system, such as a food diary, or did they ask them to calorie count using an app? And really trying to understand those small details within interventions. So thinking about why we did this survey, so really because this is a very new and emerging area, and there are really different views on this interaction between obesity and eating disorders, we wanted to ensure that the work of the collaboration is really informed by consensus in the field. And we wanted to understand if we could achieve consensus on the different items that we had identified. And in particular, with relation to the intervention strategy, we wanted to understand if they were more likely to increase or decrease risk, and if items within each cluster were likely to move in the same direction or not, so that when we conduct our analysis, we have them grouped correctly. But really, most importantly, we wanted to identify if there were any missing items that we haven't yet considered. And so within each category that I previously mentioned, we asked if there were additional items that we have missed that should be considered in our study. So we had 87 people complete the survey, so mostly female and mostly from Australia or the US. Most participants were clinicians or researchers, but also we had a really high representation of people with lived experience. So really almost everybody who completed the survey had a lived experience of either overweight or obesity or an eating disorder, or were a carer of somebody with obesity or an eating disorder. And there were 25 out of the 87 people who had reported a lived experience of both overweight or obesity and an eating disorder, which I think is a really good outcome of this survey. So I'll talk you through the results now. So starting with the individual characteristics. So looking at across the clusters of the individual characteristics, there really was consensus that everything we had identified was relevant to eating disorder risk. So in the light blue there is a rating that each of these items was likely to be relevant to eating disorder risk, which was helpful for us to know. But there were some individual characteristics that were identified as also being relevant that we hadn't picked up. So for example, in family history, it was suggested that we should consider weight fluctuation, so how often weight had fluctuated in the past, as well as a history of bariatric surgery. So we had previously identified that if, for example, a parent had had bariatric surgery, that was an important risk factor to consider for an adolescent. But it was raised that we should consider if the adolescent themselves or adults have had bariatric surgery as well. So from a psychosocial health or eating behaviour point of view, some additional items that were suggested were executive function. There were some additional mental health items, so considering a history of addiction or self-harm, considering the parent-patient relationship, social media use, particularly recently where that's been linked to disordered eating. but also to consider risk factors in relation to the personal context of the individual. So somebody may have several risk factors, but if they live in a supportive environment, they're not necessarily going to be at high risk of developing an eating disorder. And somebody who may not have clear risk factors but is not living in a supportive environment may be at higher risk. But really in this section, the strongest message that came through was that experience of weight stigma from health professionals was a really strong predictor of eating disorder risk. And this, from our point of view in our study, is going to be very difficult to look at, but it's important moving forward to consider this, particularly as clinicians. And so I just have some of the comments there that came through. So in terms of communication styles from health professionals, you know, it was suggested that microaggressions and the communication style of the provider contribute to weight stigma. Not being able to access medical care for other conditions because of somebody's weight. And also that there is high heterogeneity, even with supervised dietary intervention. So even though they may be better than people undergoing self-directed diets, that they may still experience stigma in that context. So if we move now to have a look at some of the intervention strategies. So just a reminder that in this section, we asked people to rate if different strategies used in weight management interventions were more likely to increase or decrease eating disorder risk or have no impact. And so I'll be showing this as a series of graphs, and on these graphs, the light blue colour represents a decrease in eating disorder risk, yellow is no impact, and the dark blue is an increase in eating disorder risk, with green being not sure. So on this first slide, we have a look at the overall framing of the intervention. So the theme throughout this whole first category really is that if anything really that overly focuses on weight and body weight was rated as being more likely to increase eating disorder risk, and anything focused more on health was more likely to decrease eating disorder risk. So in this first graph, you can see that if the overall intent or framing of the intervention is about weight loss or weight maintenance, it was rated as being more likely to increase risk, compared to being framed as improving health was more likely to decrease risk. So similarly, in the different communication strategies used, so if obesity was talked about as being a disease and that we needed to lose weight to improve health, that was seen as more likely to increase eating disorder risk. But if we talked about improving health without focusing on weight too much, or that we could improve health without losing weight, then that was perceived to reduce eating disorder risk. So here we look at different outcomes measured in interventions and how weight is measured. And again, it follows that similar pattern that if an intervention is focusing on measuring weight and encouraging weight loss, it's perceived to be more likely to increase risk. Where if there's a focus on a range of health outcomes, so considering, you know, blood pressure, blood results, mental health, it's more likely to decrease eating disorder risk. So some additional intervention strategies to consider in this category were really around the communication approaches or education style. So from a communication point of view, focusing on decreasing personal responsibility for weight was perceived to reduce eating disorder risk. And really considering the language and images that are used during interventions. From an education point of view, it was suggested that explaining the science of weight and appetite and how that and appetite regulation and the role of weight stigma would decrease eating disorder risk, and talking about weight really in terms of health and growth. And from an outcome point of view, it was suggested that the rate of weight loss is important to look at. So how fast somebody might lose weight contributes to eating disorder risk. So next, if we have a look at the dietary strategies that may be used during interventions. So on the left there are the different education strategies that we had included. And really in this section, it was mixed. So across the different dietary strategies or the different nutrition education strategies, there was a mix of it as to whether they might increase or decrease risk or have no impact, except when it came to prescription. So across all of the dietary prescriptions there on the right, didn't matter what type of diet it was perceived to increase eating disorder risk, as well as there on the left, categorization of foods, having good, bad foods, focusing on energy and macronutrient content. So really a similar pattern there. So looking at the delivery of the diet intervention, again, follows on from the previous slide, where anything that was more prescriptive, like using a prescriptive meal plan, using meal replacements, were perceived to be more likely to increase eating disorder risk. But then having a flexible approach, having approach tailored to the individual, and a family-based approach were more likely to decrease eating disorder risk. So different dietary monitoring strategies just in the bottom left, again, follow on from what we saw earlier, where monitoring of foods, focusing on the energy or calorie content, were all perceived to increase eating disorder risk. And the different behaviour change strategies, again, were a little bit mixed. So where they may be likely to either increase or decrease risk or have no change. So there were some additional dietary strategies to consider. So the first is the role of the family and family dynamics in food choice and selection. So if the food choices of the individual in the weight management intervention differ from the rest of the household, that was seen as being problematic. It was also suggested that providing education to the family on the risk of eating disorders and the need to be a bit more flexible and not too prescriptive, particularly to parents towards children, that would reduce eating disorder risk overall. And again, communication strategies came up. So how we talk about different dietary strategies, the use of language in talking about food, so good versus bad foods, healthy versus unhealthy foods, was considered to be important, as well as the dietary prescription, which really followed.
Hello, everyone. It seems like,
Oh.
Are you back, Heba?
I'm back. Yes, sorry. I'm not sure when my connection cut out.
Oh, just at the communication, I think.
Okay. Yeah, I'll just continue. Okay.
But, yeah, we
can't
actually see you.
Oh, you can't?
On.
Oh, okay. I'll just try turning my camera off. Can you see me now?
No, I'll turn mine off. I'm not sure. Anyway, we can hear you, so that's really good.
Okay, I'll just keep going
that's
then.
The main thing.
But maybe just pop something in the chat if you lose me again.
Yeah, no worries.
Okay, so in terms of the dietary prescription, as we saw in the previous slide, anything that was viewed to be sort of a rigid dietary prescription is more likely to increase risk, including behaviours such as weighing and measuring foods. So the third category looked at how an intervention might consider or address eating behaviours and disordered eating. And you can see that across these two clusters, everything's light blue, which means that any form of sort of addressing disordered eating, identifying the behaviours and addressing them, or promoting more healthful eating behaviours was perceived to decrease eating disorder risk. So some additional items that were suggested from an eating behaviours point of view, so screening for eating disorders and referral prior to interventions was suggested. But then there was sort of another comment that examining disordered eating behaviours in children may not be appropriate, and whether that may give them some ideas on different strategies to try that they hadn't previously considered. From an education point of view, it was suggested that providing education on excessive energy restriction may lead to hunger and binge eating, and so the need for some more flexible restriction. and the education on a healthy menstrual cycle and the links with under-eating and over-exercise, so that they were aware of that potential red flag if that occurred. But also the context within which different disordered eating or eating behaviour strategies were used is important. So while we had included some strategies such as mindful eating and intuitive eating as being parts of weight management interventions, there were some comments that it was not appropriate to use those within the context of weight management. So the fourth category looked at different movement and sleep-related strategies, so how interventions promote physical activity or address sedentary behaviour and promote sleep. So really in a similar pattern to the dietary interventions, any sort of more prescriptive exercise plans, so having a formal exercise plan that somebody needed to follow, or a prescriptive plan was perceived to be more likely to increase eating disorder risk, but promoting joyful movement, flexible exercise approaches, and really more personalised advice was viewed to be more likely to reduce eating disorder risk. So again, the behaviour change strategies related to physical activity were a little bit mixed, a bit like the behaviour change strategies relating to dietary interventions. So there wasn't really clear consensus on whether they're more likely to increase or decrease risk. And it's the same with sedentary time, which is there on the right. There was sort of a bit of a mix between whether it would decrease risk, increase risk, or have no impact on eating disorder risk. But for addressing sleep, there at the bottom, there was general consensus that's more likely to decrease risk or would have no impact on eating disorder risk, but not increase. So there were a few additional items suggested in terms of movement and sleep. So in terms of sleep, it was suggested that an intervention should investigate, diagnose and treat sleep apnea, as well as focusing on circadian alignment and total sleep time. And then really in relation to communication, there were some comments about attitudes and beliefs of trainers, personal trainers, and how that might influence risk in their communication styles. So if they really overemphasized appearance or weight loss, that would increase eating disorder risk, whereas if they were focused on healthy habits and quality of life goals as opposed to weight loss, it's more likely to decrease risk. And really it was suggested that it would be helpful for interventions to explore motivations for exercise and looking at motivations beyond weight. So focusing on the mental health and physical health motivations for exercise rather than focusing on shape, weight and appearance. So this final category was looking at psychosocial health related strategies. And again, as with eating behaviours and disordered eating, there was general consensus that these are more likely to decrease risk. So if the intervention was based on a psychological framework such as CBT, it's more likely to decrease risk. And if there was some sort of addressing of psychosocial health within the intervention as well. So finally, this looks at addressing mental health more broadly. So if the intervention recognises or diagnoses and addresses different mental health conditions, addresses weight stigma or addresses body image, that was considered to be more likely to decrease eating disorder risk. So there were a few items suggested again, so specifically around different education that could be provided in an intervention. So addressing internalised and externally received weight biases, providing some of the health at every size principles, discussing how under-eating may be related to anxiety and depression and concentration, the difficulties with maintaining long-term weight loss to really prevent that sense of failure that people may feel down the track, and strategies for normalising and addressing shame from carers and young people. And there were some comments about weight stigma that it's not really appropriate to address weight stigma in the context of weight management, and that it's not the responsibility of the individual to manage prejudices from others. And that came from one of the items we had, which was about an intervention including components to build resilience to weight management. So the last part of the survey looked at the specific delivery features used within an intervention. And here in yellow, that's just showing that there was consensus that really all of the delivery features are important to consider from an eating disorder point of view. And there were some additional delivery features that were suggested should be considered. So the continuity of care, so that's really important to be providing long-term support because weight regain down the track can lead to self-blame and feelings of failure. So support should be provided during those stages. That we need both step up and step down pathways for obesity care and multidisciplinary care. In terms of the mode of delivery, there were some suggestions about telehealth and video conferencing because there has been some recent data following on from COVID really showing that use of video conferencing and telehealth is associated with body image concerns. And then considering the intervention setting itself, things like any environmental contributors. So does the service have the right environment and the right setup? So having appropriate chairs, offering a safe space, and having a good understanding of group rules in group sessions. And then from a health professional point of view, really just saying that health professionals who are providing weight management need to have a good understanding of eating disorder and body image issues so that these risk factors can be picked up early. So in the survey, there were also a couple of sort of broad themes that came across that didn't necessarily fit into a specific category. So one was that there's likely to be individual variation in response, and so, that patient choice should be considered in the selection of different weight management approaches, and that there is high heterogeneity with intervention features. So some will have a good experience and others will have a stigmatizing and harmful experience with the same intervention. So this quote just shows that, saying that I've seen acceptance therapies promote disordered eating behaviors, and I've seen positive body positivity increase people's negative self-evaluation. And I've seen them work for others, but these things that are not so often, that are used so often, are not the answer for everybody. So the other broad theme that emerged is really the need to recognise disordered eating and eating disorders during weight management. So often that they're not recognised, clinicians need a greater awareness of eating disorders and resources to be able to address this. Individuals seeking weight management may have a higher tolerance for risky and unsafe approaches to weight loss. People with a history of an eating disorder or a current eating disorder should not be offered weight management. And risk factors may vary by eating disorder, so we need to consider the different disorders separately. So this is just another quote that we had, which is that I entered a weight management program with an active eating disorder and then was taught how to refine my eating disorder behaviours. So there were just a couple of general comments that came through in the survey as well. So one is the role of weight management at all, so that any weight management contributes to eating disorder risk, that it's not possible for this to be safer because it promotes weight bias. That protective factors don't necessarily reduce the risk of eating disorders. So we had talked about some protective elements such as CBT, intuitive eating and mindful eating. And that was said, there were some comments to say that these won't reduce the risk associated with weight management interventions. And then some comments about informed consent. So about the long-term weight maintenance of weight loss and how realistic that is. The risk with weight cycling if people sort of lose weight and regain weight frequently, and then the risk of disordered eating and the role of family in preventing this. So overall, there was consensus that known eating disorder risk factors can be considered in the context of weight management. We did identify some additional complexities, such as the role of weight stigma from health professionals and communication style and approach, and that identifying eating disorders and disordered eating prior to and during interventions is important future direction. So in terms of the EDIT collaboration, this really highlighted that we need a detailed deconstruction of interventions And we know that interventions are made up of multiple moving parts. So we need to understand what happens when we combine different strategies. So if we are combining strategies that may be perceived to increase risk, such as a more prescriptive diet or exercise program, with some other strategies that are more protective, such as CBT, what happens in those instances for different people. So I'd just like to end there by thanking our broader EDIT collaboration study team and our scientific and stakeholder advisory panels that have really informed this work, as well as all of the trialists who have agreed to share their data with us so that we can answer these research questions. Thank you.
Thanks so much, Heba. I just wanted to, I got a message from Sharon that you should perhaps try to enter the stage again so that you can come up.
I don't have that option, actually. I can try leaving the stage and coming back.
Yeah, maybe that might work. Great. There you are.
Is that better?
Excellent. So we do have a couple of questions that have come up. So I encourage everybody to ask questions. Now's the time. It was a fabulous presentation, though. Really, really interesting work, and so relevant to our practice in adolescent health. So we have a question from Louise, and she asks, would you please comment on the comment that people with active eating disorders should not be offered weight management? What if the person has health complications related to obesity or wants to move to a healthier weight for other health-related wellbeing reasons?
Yeah, look, that's a good question, Louise. Very controversial area. I mean, I think it really is going to come down to the individual. There have been some studies that have looked at the co-treatment of obesity and particularly binge eating disorder. So having weight loss as part of treatment for binge eating disorder with some fairly good and mixed results. But in terms of the other eating disorders, I don't think there's really much out there, but I'd say it's really an individual, patient-centered decision with the providers, depending on what their complications are and the priority really in terms of their overall health. There is going to be a panel discussion, I'll say, at the Eating Disorder Research Society meeting addressing that exact issue about when we could potentially co-treat, provide weight management and eating disorder treatment. So it's a hot topic.
Yeah, so from what I can glean from that, you need to consider the multiple components, those protective components of your intervention as well. That's what it sounds like for if you're, embarking on a weight management, therapy. And Jonathan has asked, is there any data regarding risk of an eating disorder following discharge from a weight loss unit program?
Yeah, so in the trials that we looked at, there were trials that sort of had followed up people from the end of intervention for 1 year to 1 or 2 years. There were a few trials that have looked at sort of longer follow-up, 4 years, 5 or 6 years, but with very small numbers. The challenge is that those trials often have high rates of dropout, as with any trial. Following people up for several years is really difficult. But that's something we're hoping to look at in more detail as part of EDIT. We do have some trials included in EDIT that have 3 or 4 year follow-up from the end of intervention. So we'll be able to have a look at that at a bit more detail at the individual level. So there isn't good data, is my answer. So the data we have suggests that there isn't really a worsening, that there may, there's some individual cases that may have developed binge eating disorder or binge eating, but on the whole, there isn't a worsening. But again, the studies have a dropout of about 50%, and we don't know what happens to those people, which is one of the concerns.
Thank you. So we have another question from Daniel. Great presentation. I like the approach of utilising data from previous studies to answer new research questions within the Ideas Grant. Was this an easy thing to achieve, and would you have any suggestions for people trying this approach? How did you get funded?
Well, the approach that we used, I guess really I'll say that the way we designed our studies is based on another study. So it's based on a study called the Top Child Collaboration, which is looking at the early prevention of obesity. So we really modelled our study on the methods that they've used. But in terms of the Ideas Grant, really we sort of started planning this very early and had buy-in from different collaborators early on, started talking about the idea with people. And we also approached trialists before putting the grant in, so that we had sort of in principle agreement from some of the trialists to share their data that we could show in our Ideas Grant application. But I think really just, I don't think there's really a magic answer to how these grants are successful, but I think showing the feasibility that you will be able to bring the data together is important.
Thank you. And Louise, again, related to Daniel's query, what are some of the practical and ethical considerations to sharing data in this way?
So I guess with the ethical considerations first, it can be tricky in terms of the individual trials and if they obtained consent to share data early on during their consenting process. So for some of the more recent trials where that is built in a bit more routinely, it's less of an issue to some of the older trials. So there is a bit of a process with, for some trials, obtaining a waiver of consent. There are also some practical issues in terms of sharing data, particularly across countries. But also, I guess, from a practical point of view, in terms of bringing the collaboration together and having people trust you enough to share their data with you is probably where most of the work lies. So having really good communication and engagement with trialists so that they feel confident enough to share their data with you. And we're right in the middle of that data sharing process. So while we've had really good engagement so far, it's going to be a lot of work receiving the data.
Great, thanks. Very interesting. And Maya has asked whether this is on a different topic about COVID and the impact of COVID. Have you noticed an effect on eating disorder trends in young people during COVID lockdown? And perhaps why?
Look, I'm not completely across this literature, but I know that there have been some studies coming out of the eating disorder field showing an increase in disordered eating. I've definitely seen, papers that have said that there's an increase in presentation to eating disorder services and waiting lists for eating disorder services. So I think there has been an increase during COVID, but I won't comment further because that's not really, I'm not across everything in that area.
And whether or not, I think that there have been reporting of increased presentations, and certainly anecdotally in our own services there's much more, and maybe it is related to the increased psychosocial distress in general, although we don't entirely understand that. But we do know that young people are experiencing much higher levels of mental health issues, and so that's likely to, increase the risk factors as you described. So, but it would be great to find out more on that as time goes on. So we have a question from Yasmina. Are you aware of any studies with adolescents that used risk minimisation factors, i.e. mindful eating, intuitive eating, etc., that have led to unintentional weight loss? I think you were talking about this.
So we've had a look at, there have been trials that have included mindful eating and intuitive eating strategies as part of a weight management intervention. So they're sort of incorporated into a weight management intervention where some change in weight is still the goal. We did conduct a systematic review, which has just been published recently, having a look at if these weight neutral type interventions that really don't focus on weight loss at all, but use some of these mindful eating, intuitive eating strategies in young people, and really only identified 3 very small studies. And with those studies, I think some led to a small amount of weight loss, others didn't. So not really conclusive at this stage. But from the adult literature, you do tend to see a small amount of weight loss with these strategies as well.
So not yet evidence to recommend it?
Not yet enough evidence. Yeah.
So I have a question while we're waiting to see if anyone else has any questions they'd like to ask, because we still have a few minutes. So the interventions that you saw that, present risks for young people in developing, weight management interventions that present a risk for developing eating disorders, is that something that's specific, or that young people and adolescents in particular are more vulnerable to than adults? I mean, is this a specific issue for adolescents?
I don't think it's specific to adolescents. So there have been systematic reviews in adults which really show a similar trend. So we're looking at those data at the moment of adult weight management trials, and it's really the same sort of trends, that for most people there's a reduction in risk, and then where trials have looked at it, there's a small number of people, maybe about 5%, who have the onset of binge eating or have an increase in risk. The challenge is that most of these studies don't look at the individual level. So it's really just been a handful of studies that have reported it. And so I think that's what we're eager to look at with EDIT, when we can look at the data across trials and see what the true numbers are.
Great. Well, that, it will be so impactful, so important, your studies. I was also interested in the relationship or the perceived relationship between sleep and weight loss. And that programs that focus on sleep can be, helpful for weight loss, as well as not, being safe as well. And what you think the mechanisms might be, if you have any ideas on that. Sorry.
Yeah. Yeah. No. I mean, from an eating disorder point of view, I'm not sure what the mechanisms are. I mean, what we try to do is include really all strategies that may be part of weight management interventions, just to be as comprehensive as possible. So, but Natalie may have Louise may have a better idea on that one. But yeah, I'm not entirely sure.
That's fine. So Louise has popped a reference in the chat, so that's great.
So that's the review that we did that looked at the weight neutral interventions in young people. So the mindful eating, intuitive eating type interventions conducted in adolescents.
Right. Excellent. We'll definitely have a look at that. And I was also interested in the comment from some of the survey respondents that providers are not responsible for stigma, that weight-related stigma that might be incurred or occur outside the program itself, and whether, thinking about sort of the importance of the broader context, as you said, that, when we're implementing various programs for these young people, whether that is, or I suppose just provide a little bit more insight into that perception, that we're not responsible for the broader impact.
Yeah, so what that comment was about is that we had included as one of the intervention strategies that an intervention may provide some training about building resilience towards weight stigma. So there have been some trials that are looking at building resilience towards weight stigma and teaching people how they may address weight stigma or communicate in relation to that. And we had another strategy which was sort of about teaching communication styles to help people address weight stigma within their own personal circles. And the comments were about not the providers, it was about that the individual person shouldn't be held responsible for addressing that stigma themselves, that we need to address stigma at a societal level and with professionals, which we do. But it was saying that it was sort of inappropriate to be teaching those strategies to the individual, because it's sort of placing that responsibility on them to address the stigma. But I think so that's really what that comment was about.
It was my misunderstanding, because I would have thought it would be so important. Yeah.
No, that's okay.
Great, thank you. And Louise has said in the chat that sleep interventions are very important for many aspects of health in young people, including obesity management. And it's incorporated routinely in weight management services and programs. So that's really great. So I think, we may have come to an end. That was a wonderful presentation. So thank you so much, Heba. It was really great. And I wish you all the best for the rest of it. And we would love to have you back when you have, you know, the next phase of the data collected and analysed. So that would be really wonderful. Thank you. And
definitely.
yeah, I think that we've come to an end. So I just wanted to thank everybody for your participation and for joining in. And yeah, so a big round of applause for Hiva. And anyway, we look forward to everyone coming together again in a month's time. So thank you very much, and say goodbye.
Thanks, everyone. Bye.